Okay, maybe we'll get started and just keep admitting people as they join. So thank you everyone for being here today. This is our fourth session of this series, How We Talk with Research Participants. Um, so I'm Allie Molnar, and then I'm here with my colleague Ann Buffington, and we make up ICTR's Recruitment and Retention Resource Center. Today, we are here to listen to a presentation titled An Adapted Methods Motivational Interviewing Approach for Discussing Trial Information with Study Participants. And we have an amazing team here today ready to present, which Anne will introduce in just a quick second. If my computer wants to go. Just a reminder, as I said, this is the fourth out of 5 sessions that we have in this workshop series. So we'll have our final one that's actually a panel discussion, which we're really excited for as well come December 16th. Many members of UW-Madison research community from various different departments and participant populations will be represented on the panel. And also a reminder that our recordings from past sessions are up on our How We Talk with Research Participants webpage. So you can find those there, and you'll be able to find additional recordings as well once we have those posted. I won't go through this again because if you've been with us, you've probably heard this many times, but basically Ann and I are here to help you with your recruitment retention journey, however we can be useful. And then a few other reminders. So we definitely encourage questions. You can unmute yourself and ask your questions or put them in the chat. We'll have time for questions at the end as well. Reminder that we are recording the session and we will share the recordings afterwards along with a summary of any question and answer. And then we'll have a link to our brief evaluation survey at the end. It's just, I think, 5 questions. So if you could fill that out, that's super helpful for us. And we'll send that out also in the follow-up email as well. And then please ensure that your questions in Zoom chat comments do not include any confidential information or details that could identify study participants. And then last, if you have any questions about what you can or cannot say to your study participants, always reach out to your IRB reviewer. They can help you there. So I will pass it over to Anne to share a little bit more about our speakers.
Great, thank you, Allie. So as Allie mentioned, we're lucky to have a whole study team with us here today. I always like to hear from multiple members of teams, and this is headed up by Dr. Yinka Shiyanbola, formerly UW professor, now at the University of Michigan College of Pharmacy. And her research is really focused on advancing the use of patient-centered interdisciplinary approaches to improve diabetes and related health outcomes, medication use behaviors, health literacy, and health equity. And she is PI of the ENRICH study, which we are going to learn more about today. And it's a behavioral clinical trial being conducted out of Milwaukee. She is joined by Dr. Martha Maurer, who is here at the UW School of Pharmacy and serves as the study coordinator for this trial. And Martha contributed to developing the materials and process for the methods motivational interviewing communication approach that they're going to talk about today. And if you could do next slide, Allie, thank you. They are joined, we have Delicia Morris, who's also out of the UW School of Pharmacy, who is a research specialist located in Milwaukee. And she manages recruitment, enrollment, ongoing engagement, study retention activities with participants in the ENRICH study. And then last but not least, Shary Perez, the Community Health and Research Program Director at the United Community Center, also works as a research specialist and along with Delicia, does excellent work in recruitment, enrollment, engagement, and retaining study participants in the trial and really focusing on Spanish-speaking participants. And this study team gave a talk earlier this year on their recruitment methods for this trial, which was a wonderful presentation. I will put that link in the Zoom chat, and if you're interested in more sort of their community engagement methods, you can check out that talk as well. But we will go ahead and turn it over to the speakers, and they can share their slides.
Okay, great. Thank you, Shary, for sharing. Okay, good morning. Oh, sorry, not good morning. Good afternoon, everybody. And thank you for joining us today. And we are here, like you already heard, to talk about the adapted methods motivational interviewing approach for discussing trial information with study participants. And it's so much of a delight for me, for my team to be here, to be able to talk about the strategies that we currently use in our R01 clinical trial. Next slide, please. Oh, can I make a disclaimer in the prior slide? Thank you, Shary. So one note that I wanted to make is if you do want to replicate this approach that we're going to be talking about, we ask that you speak to our team because there's still some ongoing studies related to this approach that is being used. Thank you. Okay, so this is our outline for today. I will start off before I hand it over to the rest of our team. And I will start off by first talking about what is motivational interviewing. I know it's something that is familiar to a lot of people, but just to make sure I set the foundation for what we're talking about today, we'll talk about motivational interviewing process. Then I will introduce what exactly is MMI, which is Methods Motivational Interviewing Approach, and how is this currently used. And how would you use it in a clinical trial? And then I'll hand it over to Dr. Maurer, who would then tell you about an example of how we've used this approach in a prior pilot trial that is currently published in Nature Scientific Reports. And then she would hand it over to the rest of our team, Shary and Delicia, who would then talk about how we are currently using it in ENRICH R01 trial, like I mentioned at the beginning. And you will see a little bit of a different flavor and different ways that are currently being used, both in the pilot trial and in the ENRICH trial. So you can see sort of those differences in our adapted approach. Then we will show you a video of what this looks like, which is going to be very exciting to show what that is. And then we will have a discussion. So one of the things we're going to tell you as you review the video is to think about, make a couple of notes in your head or make a couple of notes on a sheet of paper on things that you're seeing and the things that you want to talk about when we get to our discussion. And then we'll wrap up. Next slide, please. Thank you. So again, to set the foundation for what motivational interviewing is, it's a style of communication that is focused on the person. Usually the individual has a goal that they want to accomplish, and you are thinking about how to change their behavior related to their goal. It is used a lot in smoking cessation to get people to stop smoking. It's used a lot as somebody who is a pharmacist in trying to get people to take their medications. So it is a style of communicating with a person to increase their personal motivation to do that behavior and change their health behavior, and also to increase the commitment that they have to also doing that behavior. But what is interesting about this approach is that you work with that person in them thinking about what are their reasons for wanting to do that behavior change. And it's done in an atmosphere where there is acceptance and where there is empathy while you are talking about these behavior changes. And one of the things to note is a lot of the times this interviewing approach is used for people that most of the times are unwilling to want to change their behavior or are feeling ambivalent whether they want to change their behavior, which is the reason why I use smoking cessation as an example and also use taking your medicines as prescribed as an example. Next slide. Thank you. So motivational interviewing is a process that is, like I already said, is used in interventions. But one of the things that we are seeing is that it's also a process that can be translated in clinical trials and getting people to be willing to participate in a trial or be retained in a clinical trial. So it provides information about the trial and what the participants at that point, they are potential participants. And that is a key word because at that point, they are not yet enrolled in the study. They are thinking about enrolling in the study. And what you want them to consider is Do they want to commit to changing whatever targeted behavior is as part of the trial? Are they committed to completing the trial? And are they willing to do that, irrespective of whether they are successful in the trial or not? So we're going to show you an example related to diabetes, which is what our team does. Personal success for somebody could be, I did better with my hemoglobin A1C. But whether you do better or not, are you still willing to continue being in the trial? Next slide, please. So now that I've sort of set the stage for what motivational interviewing is and how it's used a lot in behavioral change interventions and how it could be used in clinical trials, I'm now going to talk about the MMI, which is the Methods Motivational Interviewing Approach. So this was developed originally by Michaela Keenan out of Stanford University. A couple of she and her colleagues designed this approach. And what it means is that you are actively involving participants in learning about what is the research question within this clinical trial? What is the process that is going to be taking place in the trial? What is the scientific reason for why you are even using the methods in the trials? A lot of the times in trials, we do survey assessment, for example. Well, what is the reason for why we are doing that? And again, like I mentioned, is to diffuse any unwillingness, any ambivalence, and think about what are the positives and the negatives of whether they should enroll in the study. So it's a cognitive process where the participant is potentially thinking about that in an interactive session prior to being enrolled in the study. And what it does, it allows the trial participants to consider, do I want to be committed to all these methods that they are going to be telling me to do in the study? For example, I'm going to get you're going to get a blood draw. Do I want to be committed to that? They're asking me to complete so many surveys. Am I ready to be committed to that? To complete all the study assessments, irrespective of whether I am randomized to usual care or not. And do I want to even successfully engage in the study? And then do I want to commit to changing my behavior as part of the study? So like I said, it's a cognitive process where the participant is thinking about all of these decisions before they enroll in the study. Next slide, please. So then what we did in the study that Dr. Maurer is going to talk about is we adapted this motivational interviewing approach in the study that we published. And what we did is we emphasized health literacy principles a little bit more. And the reason is because one of the things we found is there's a lot of jargon. There's a lot of terminology used when we are discussing trial information and communicating with trial participants. And so one of the things we wanted to incorporate is while we want to use this approach to increase transparency about the clinical trial, getting them to talk about and think about their commitments to this, we also want to do it using plain language. We want to show infographics and using visual representation to further increase research literacy. We want to use things like a road mapping that is pictorial. And then we want to use open-ended questions, which they're going to talk about at the end, asking, what questions do you have for me? What part of this process needs more explanation? And at the end of the day, it is guiding participants about the purpose of the trial, what randomization is all about and what it's going to look like in the study, what are the objectives, and then also what the timeline is. Next slide. Okay, and then I'll turn it over to Dr. Maurer.
Thank you. Thank you. Good afternoon, everyone. So we will be presenting two examples of our team applying the Methods Motivational Interviewing approach. Actually, we applied adaptations of the approach. So the first example, Shady, if you could go to the next slide, is from a few years ago. And so in 2023, we conducted a small randomized controlled trial involving enrolling Black adults in Madison. And we used an adapted MMI approach focused on health literacy principles. And you can see here, we published the findings earlier this year. So invite you to look up the paper if you're wanting to read a bit more detail. Next slide, please, Shady. So this pilot tested 2 versions of a diabetes self-management education program. So one of the versions was a standard 6-week evidence-based program, and the second version was an 8-week version that was an enhancement to the evidence-based DSME program, where we added peer support, and we also added 2 additional group sessions, which made it an 8-week program. And just for a little bit of background, participants were enrolled in the trial for 6 months. So the adapted MMI approach involved a prerequisite orientation, which took place before the informed consent process. So the participants came to a community location here in Madison. It was a community center. And the PI, so Dr. Shiyanbola, presented a 20-minute interactive PowerPoint presentation in person in the community at the screening session itself. And as she mentioned, the presentation covered general information about behavioral clinical trials using plain language, using infographics. And it also covered details regarding the specific trial, such as the time commitment and expectations for their participation in the trial. So then after that presentation, Dr. Shiyanbola, certainly answered questions, and then she left the room so that we could sort of address potential power dynamics. And the study coordinator then conducted a group discussion with the potential participants to really delve into the pros and cons of why they may or may not be interested in joining the study. And this lasted for about 15 minutes or so. And it provided an opportunity for the individuals to really interact with the study team and gave them some sort of time and space to clearly think through, what was this something they were comfortable enrolling in, and, asking questions and things if they weren't. So then once that discussion concluded, individuals who were interested in enrolling in the study, then they stayed around and went through the complete informed consent process. And individuals who were not interested or decided the time commitment wasn't something that would work for them, or another reason, they just went on with the rest of their day. Next slide, please. So then at the end of the trial, we conducted 2 focus groups, one with the control group, so the individuals that participated in the 6-week program, and then a separate focus group with individuals who were in the intervention 8-week program. And we really wanted to get a sense of what their perceptions were of going through that whole prerequisite orientation process, and listening to Dr. Shiyanbola's presentation and going through that discussion with the team. And what we found was that participants, by and large, reported very positive experiences. They shared with us that they gained a better understanding of the information, what the study was going to be all about, what the expectations were, the time commitment. They also mentioned that they were appreciative of being able to hear about the rationale behind randomization and what does randomization even mean. So they really appreciated having that information ahead of time. They also noted that they really appreciated the transparency and clarity about the study expectations right at the beginning, so they could make that informed decision for themselves and really consider whether it was going to work for them or not in their personal schedules. So overall, they reported that the orientation provided a safe and welcoming environment. So similar to what Dr. Shiyanbola mentioned earlier in terms of creating that acceptance and empathy, it really allowed them to provided a space where they felt comfortable raising their concerns and questions. Next slide. And now I'll turn it over to Shady.
Thank you, Martha. So now I'm going to be sharing a little bit more about ENRICH. This trial. It's called Enhancing Diabetes Management with Pharmacists and Community Health Worker. And the reason why ENRICH was created was because it was realized that, diabetes is hard to manage, and sometimes our community don't have the right information, or they don't know who to ask for that information, or basically they have the information but don't know how to manage their diabetes. They need a little bit of more support. So the purpose of this study was to learn what was the best way to improve that pharmacy-related care for managing diabetes. So we reach out to adults who are dealing with uncontrolled diabetes. And the reason why we did that is because some people are not taking their diabetes medicine as prescribed, or they might have some life challenges that might be impacting, the care that they're receiving, or what they know or what they believe about diabetes and medicines might be also in the way in terms of being able to manage their diabetes. So with that, what we did was a randomization study. And with this randomization, we have 4 different groups. So participants have the possibility of being assigned to one of those 4 different groups. And depending on the group that they're assigned to, that's the support that they will receive. So we have group 1, 2, 3, and 4. Group 1, or the blue group, is those individuals who will continue their regular visits with their doctors and with their pharmacists. They're not going to get additional support. It's the control group. We also have group number 2, or the green group, and in that group, participants receive additional support from a pharmacist, and it could be in person or virtual or over the phone, I'm sorry. And basically the support that they receive is how to manage their diabetes medicines. And, they have conversations about how are the diabetes medicines working, if they have any side effects, things like that. We also have group number 3, or the purple group. And in that group, the participants receive additional support from a community health worker. And the community health worker helps them address the challenges that might be impacting their diabetes care. And that could include receiving information that they might need about, healthy foods, or how to talk to their doctors, or how to get transportation to get to their appointments. All of those things that are beyond what the pharmacist will be doing, and it's more about those life challenges. And then group number 4, or the red group, that's the group that receives both the additional support from the pharmacist in terms of managing diabetes medicines, as well as the community health worker to address those life challenges related to diabetes care. And then all our participants also receive compensation for participating. So this is something that we also explain before they decide to participate in the study. So in terms of compensation, participants receive $10 for having a phone call with us, with me or Delicia, where we can do a pre-screening and ask them a few questions to see if they will pre-qualify for the study. After that, when we check all of those questions, then they go to an in-person appointment where we check their A1C. To be able to participate in the study, their A1C needs to be 8 or above. So that's why they come in person and we check their A1C. And then they receive another $10. So it's $10 for the phone calls and $10 for coming in person to check their A1C. And then once we check the A1C and they watch the videos, and if they decide to participate in complete consent and they're now part of the study, then they will receive $25 during the first month. And after that, 3 months, they receive $45, and we see them again at 6 months to receive $55. And we do A1C and survey again just to check how it went after receiving that support. And then at the end, they receive $75. So all of this information is something that we share during the videos to make sure that participants understand how they can get up to $220 and what is the process and each one of the steps of being part of this study. Now I will pass it over to Delicia, who will be sharing more information about the videos that we share with the participants.
Delicia, I think you're on mute.
Sorry about that. So after we show them the videos, what we do is we go through a pros and cons situation for them. So is this my correct slide up? I'm sorry.
Yeah, this is the one that shows the Spanish one, Delicia. Then the next one is the pros and cons. Yeah.
So we always tailor our slides, our videos to if someone speaks English or Spanish, we give them whatever they prefer, whatever they feel most comfortable in. Next slide, please. And we've noticed that when we are talking to them about the videos and the pros and cons of the video, we actually do have to break down the pros and cons of each group, because many of people will tell us, hey, the pros of it is that I'm learning about my diabetes, and we have to remind them that they could be randomized into the first group, where it's the usual processes that they have always been doing with their pharmacists or healthcare providers. And it's the reminder that this is a randomized study. You cannot pick which group you're in. And if you're in our group 1, where it's usual care, that might not be a pro that you're learning about diabetes. So we make sure they understand which groups do what, as well as help them understand more the pros and cons. Because for some people, they automatically think they're going to learn about their diabetes. For others, they think if they're in group 4, where they're learning with the pharmacist and the community health worker, that they should be getting paid more. So it's an understanding level through each group and what the pros and cons are. So we're going to show you the video. It's about 10 minutes long. We're going to ask you to think about the following questions that you're watching this video, and we're going to discuss after. So the questions we're looking at is, what did you like about the video? Hopefully you do like the video. What would you change about the video? And if you were someone considering enrolling in the study, what would you find helpful in the video? Take in mind that we are dealing with people from very competent, literate professionals who are diabetic, all the way to people who haven't had any literacy at all. We've taken a lot of time to make sure our videos can capture the average people, as well as propping up those who may need more help. Next slide, please.
All right, now I will share the video. Let me know if you have any issues listening to the audio or anything.
Hello, my name is Dr. Yinka Shiyanbola, and today I'm going to be talking about ENRICH, which is a research study that looks to improve how we manage diabetes for adults. But first, let's talk about clinical research and what it means. Clinical research looks at new ways to prevent, detect, or treat disease. You might also hear clinical research referred to as clinical studies, clinical trials, research, trials, or protocols. Researchers ask volunteers to help test new medicines or new ways of doing things during these trials. Some of the things that clinical research tests includes new devices, such as blood glucose testers for people with diabetes. However, in this research, we are doing behavioral research, which is one kind of clinical research. This could mean testing the introduction of a new routine to improve a person's health, such as changes to diet and exercise. Also, in this ENRICH research study, we are going to do the research with community members together. The purpose of a clinical trial is to determine if the treatment, prevention, or behavior changes that are being studied are effective. We will be testing whether a new behavioral intervention is effective. To do this, participants will be evenly placed into different study groups. The best way to do this group placement is called randomization. Next, we are going to learn deeper about this word, randomization. Randomization is a way to use chance to place study participants into different study groups. Every participant has a chance to be put into one of the groups. No one can choose which group the participant is placed in because it is done by a computer program. While at first it may seem unfair that you can't choose which treatment you will receive, there's an important reason why. Randomization helps ensure that the results of the clinical trial will be trustworthy. That's because randomization helps prevent false results due to bias. Bias occurs when the results of a clinical trial are affected by human choices or other factors not related to the treatment being tested. For example, without realizing it, a researcher might place healthier people in the new treatment group and sicker patients in the usual treatment group. This could make the new treatment seem more effective or safer than it really is. This might affect trial results. Randomization helps ensure that this does not happen. While deciding to take part in clinical research, you are taking an active role in a decision that affects you. We will touch base on more information that you can use to help you make your decisions. Now, let's move forward to talk about our trial. The ENRICH trial was formed around the idea that it can be hard to manage diabetes. Sometimes we just don't have the right information. We don't know who to ask, or we just don't know where to start with managing diabetes. The purpose of this study is to learn about the best way to enhance pharmacy-related care for managing diabetes. In ENRICH, we have 4 different groups that you have the possibility to be placed into. People in Group 1 will continue their regular visits and interactions with their pharmacist. People in Group 2 will receive additional support from their pharmacist, either in person or over the phone, on how to manage their diabetes medicine. People in Group 3 will receive additional support from a community health worker to help address challenges that may be impacting their diabetes care, like receiving information about healthy and affordable food options, different transportation options to get to doctor's appointments. People in Group 4 will receive both the additional support from their pharmacist on managing their diabetes medicine, as well as from a community health worker to address challenges related to diabetes care. To be able to determine which additional support is more effective, we already measured your A1C levels today. We showed that you are eligible to participate in the program. We will check this A1C level 2 more times during the program. We will also ask you other information, like how you are taking your medications and how your views about diabetes medicine, your self-confidence in managing your diabetes, and other items related to managing stress and communicating with your health provider. We will ask you this information using a survey. Success from this study will be used to address the main issues adults with diabetes face when it comes to managing diabetes and preventing complications. Our hope is that by addressing these topics, we will understand how to improve the health of adults with type 2 diabetes and help us live longer, healthier lives. Now, we will be talking about the time commitment the program will require. The amount of time required for the program will depend on if you are placed into groups 1, 2, 3, or 4. Let's break it down. If you are placed into group 1, there's not initially an additional commitment, because your interactions with your pharmacist will stay the same as they currently are. If you are placed into group 2, you will spend about 3.5 hours total in the first 6 months having phone calls or in-person sessions with your pharmacist to talk about managing your diabetes medicine, which may also include helping with side effects. If you are placed into group 3, you will spend about 5 hours total in the first 6 months of the study, having phone calls and in-person sessions with a community health worker who will help you with life challenges that may be affecting your diabetes care. If you are placed into group 4, you will spend about 8 hours total talking with your pharmacist about your diabetes medicine and also with a community health worker discussing how to get help for challenges affecting your diabetes. At the middle and end of the program, all 4 groups will come to data collection day to check A1C and complete survey. Now, let's talk about the compensation that you will receive for participating in the study. Today, you will be receiving $20 for completing the screening and completing the first survey. If you enroll in the study in 1 month from now, you will receive an additional $25. In 3 months from today, you will receive another payment of $45. When we meet again in 6 months from now, we will check A1C and do a survey. Then you will receive another payment of $55. Lastly, 1 year from now, we will check the final A1C and do the final survey, and you will receive an additional $75. This means you are receiving a total of $220 for participating in this study. One thing you can do to help us prevent research bias is to participate in the whole process of the study. You might wonder, why is it important that everyone participates in the whole process and completes their A1C and survey? Let's take a look at the picture here. If everyone completes the program and completes the assessment, including all people who are in groups 1, 2, 3, or 4, we'll get a true picture whether groups 1, 2, 3, or 4 are more beneficial. Now, looking at the example on the bottom, where only part of the participants in groups 1 and 3 completed a survey, groups 2 and 4 would look more successful than they really were. We want to get a true picture about the program, even if we learn that one group wasn't helpful for some. Since we really want to learn which type of support adults need to improve diabetes management, completing all your A1C checks and surveys helps us to learn this. It will also prevent bias while doing the study. Now, let's talk about some of the possible pros and cons of being a part of the ENRICH study. We asked others who are currently in the study what they think are some of the positives and negatives of being in the study, as well as the positives and negatives of not being in the study. Some of the potential positives of being in the ENRICH trial are to have help with lowering A1C levels and having a support system during your diabetes management journey. Some of the negatives of being in the study may be the overall time commitment and the possibility of not being randomized into the group of your choice. We have reached the end of the orientation period. Now, a research team member will discuss any further questions you may have about this study and will also further discuss the positives and negatives of being in the program. We want to help you make a fully informed decision that is going to be best for you.
Thank you, Shary, for playing the video. So if we could go back to the slide. Okay, well, thank you all for indulging us with that video and watching that. And so now we want to have a discussion and to sort of finish up the rest of our presentation today. And feel free to put things in chat, come off mute. What did you like about the video? What would you change? If you were to use this adapted MMI approach like we've talked to you about today, what do you foresee as a possible challenge using this type of communication approach? And if you were somebody who, if you were someone considering enrolling, would you find it helpful? And thank you to those who already putting things in chat. I don't know if one of our, let me see. Okay, diagrams were really good. I love that we ended with, we want to help you make a fully informed decision that is going to be best for you. Thank you. Okay, we discussed retention in the video. Yes, and thank you for mentioning that. And the reason is the original MMI approach actually was designed to improve retention rates in clinical trials. So it's a good thing that you picked up on that. Like the key points were shown. Right, thank you. Okay, what do you see as possible challenges? Thank you for all the positive things they're saying. Oh, okay, more positive. I appreciate that you mentioned why it's important for everyone to complete the surveys. Exactly. Again, the reason is because when we think about study assessments, there's a lot of assessments you have to do in clinical trials, right? And no one really takes time to explain to participants, why do we even do it at all? And should I just do some and not do the others? Is that okay? So that's the reason why the emphasis of this approach is to explain the reason. And also to reduce, again, reduce the number of incomplete data that you might even get in your study trial, your trial as well. Oh, thank you for saying that you love the approach. Thank you. What else? What would you change? Let's think about what would you change or what do you see as a challenge if you were to use this communication approach? You've heard us talk about two different ways. I think Dr. Maurer spent time talking about the interactive one where I was in the room. And then you also heard Shary and Delicia then spend time talking about the video. So you've seen face-to-face and then you've seen video. So two different ways in being used in a trial. Okay, length, okay. Attention spans. As that is coming in, I'm gonna call on either Delicia or Shary to comment on some of these challenges and if that resonates with what they've also heard on the field, in the field.
So when it comes to length and attention spans, what I try to do when we're in the study rooms with them, we're never too far away. I try to ask them to reduce their distractions. So I try to ask them to like put away their phone because sometimes they'll try to like be on their phone and watch the video. And so instead I offer them like snacks so that they can feel like it's a movie experience. Like, hey, while you're watching our video, would you like some water? Would you like a snack? Could you put away your phone so that you could fully focus? Just because it is easy in general to just be distracted. And we put them in a quiet room and we're very close. So to minimize distractions.
Thanks, Alicia. Okay, other comments. Length of video might not work for all studies if people have less time to play a video or cover this content verbally.
So I'll
Yeah,
answer
go
that
ahead.
question also. So we do have times where sometimes they have qualified for the study, they definitely want to join, but they need to go. So we give them a couple different options. Option one is I can send you one video at a time via cell phone or email, whichever method of communication works best for them. And I do one at a time to make sure that they've actually watched the first one, and then I can follow up with some questions. And then I sent the second one. And then we have other participants that will schedule to come back in person with us and watch them with us. So whichever they prefer, we'll do.
Thanks, Delicia. So that answers the question that they can immediately get their questions or concerns answered. Oh, sorry, I think I skipped one. This is silly, but it was too long to have such a soothing voice. Okay, so getting again back to the length, and I think I see something about pacing as well. There is a question about, there is a comment about people cannot immediately get their questions or concerns answered, or wait, maybe they can. And I think, Delicia, you kind of alluded to that, is that they cannot immediately get. So Delicia, do you want to respond to when people watch the video at home, how do their concerns or questions get answered?
Yeah, so when we're in the office, we're right by them. So that's how they answer it in the office. And when it's sent to them, then I make sure that I'm right there via phone to answer any questions. So any questions they have right away, I make sure that I answer for them.
Okay, thanks. So other comments, I didn't think it was too long. So we kind of see a variation, right? With some people thinking it was long and some people didn't thinking it was long. And so, and that's something, it's like I said, it's an approach that can be tailored. And so depending on your type of study, that is something to think about. Like you heard when Dr. Maurer was speaking, she talked about face-to-face where we had time in a room to talk and spend. So that obviously was longer versus another study, which is like a 10-minute video. So think about how you could tailor it, this communication approach for your own trial. Comments, great ideas. The wonderful thing about the soothing voice is there's no level of push, and love the pace. I don't know, Shary, do you want to comment on that, about how it was soothing versus it feeling forceful? I don't know if you got any reactions to that in the field, or if you have any comment.
Yeah, I think that's one of the main things that people appreciate, because most participants, once they sit down and listen to the video, they have talked to us over the phone, but sometimes they're in a hurry or they don't have the time. So being able to sit down and have the time to watch everything on the video and ask questions because we're there, they are very appreciative of that. And at the same time, also, I've had participants telling me, I really like that I can go back and rewatch one of the slides if I want to, or I can pause and then talk to you about what I just saw in the video. Because that gives them the opportunity to process everything and being able to decide without feeling like I'm standing right next to them and I'm looking at them for them to decide, which sometimes happen with the consent form, right? So by having the video, it's a good opportunity for them to be alone, looking at the video, thinking everything, and then we're just right there if they have any questions.
Absolutely. And one thing I want to emphasize, as Shary said, is allowing them to cognitively, and that's why I talked about that at the beginning, is that it's a motivational and interviewing approach. It's they are the ones deciding for themselves without it feeling forceful, without it feeling like we are asking you to do this and sign the form and let's enroll you in the study. And so that is getting to that idea of let it be soothing. You have your private space, like Delicia said it, you cognitively decide on your own if you want to do this or not. Other comments, asking key study questions after the video can be helpful to know they listened and understand the study. And I believe, I don't know, Delicia, Shary, that is something that we do to sort of check in whether they listened and understood the study details.
Yeah, that's part of the pros and cons as well. You know, right away after the first video, we asked, did you understand what was happening? What would you think is like the summary of the video? And they'll let us know what they thought about it, what they are understanding it to be. You have all kind of different responses of, being happy to help with research, to wanting to learn more about diabetes, to just wanting to know more information about like our processes and how long everything just we get all kind of questions when it comes to the videos, which is great because that's how we know they're paying attention. And then we also have times where the internet is out, and when the internet is out, it is us reading the slides and going through them. So it's like we have plan A, B, C, D, E, F, G. So it's like if the internet is out, we go right to paper, and that includes us reading off the slides if we need to.
Thanks, Delicia. So something that I want to emphasize, Delicia said, is remember I said the adaptation to emphasize health literacy, sort of using that teach back, like I talked about, to make sure, did you understand it? You know, can you tell me what you heard? Like Delicia said, sort of a summary about the study. So that is also to think about in sort of your adaptation of this approach. Other comments, really like the video because we can ensure the correct message is getting out consistently, as opposed to having a person do it, as there are good consenters and not so good consenters. And just like a warm, kind voice, I can see building trust, you can conveying care. So I don't know, any of our team members want to talk about how, in terms of using this communication approach to build trust. What have you heard from the field? Anyone on our team want to make a comment on that?
I'll jump on what Shady had already said. A lot of the times myself and Shady are the ones making the phone calls, so they're already familiar with our voice. So when they come in, depending on the personalities, they already feel comfortable with us. And so just listening to the information, we're able to be, very laid back and say, hey, this is not a force. Like you might have different life circumstances where you feel like for financial reasons, even you want to just join the study. And it's like, if this isn't a good fit for you, for your health, for your time, for the transportation that it may take to get to us, you can leave at any time. No one is forcing you to be here, because sometimes when people come in, they could confuse our research study with a medical appointment. And then we have to re-explain what our research study is, why we're there, what we're doing. And we make sure every step of the way that they get the understanding of what we're doing, why we're doing it, how we're different from a medical appointment. And at any time, whether they qualify the study or not, we stay kind and polite, because many of those people have referred people to us, even if they didn't qualify for our study, because we make sure to treat every single person respectable and with the utmost care.
Thank you, Delicia.
I would like to add too that for the participants, I know that being able to see Dr. Yinka there, because she's not in the clinic, of course, it's just us. It's also something that increases trust, because they see who the PI is, and they've seen her face in the flyer as well, so they can kind of relate both things because Dr. Yinka's face is there.
Thanks, Shary. So we have a question, and is it okay if I ask you to respond to this? Can you describe how you made this video, and do you have tips? I know you kind of work with Tina on that.
Yeah, absolutely. So we essentially recorded it using PowerPoint, a PowerPoint functionality. I don't know all the specific details, but we could certainly, if you send an email, we could certainly share more. And then our team member used the PowerPoint video that she created. You record it slide by slide, and then she worked with an IT person here in our department to convert it to a video. And then we actually have it loaded up on a UW Media Space site. So that also includes like closed captioning and things like that. So the version you saw today is slightly different than what appears to the participants, but yeah, that's how we made them.
Thank you. Okay, we have about 3 minutes left for any final questions before we do our wrap up. Any final questions about this communication approach? Any thing you want to hear from our team about using this communication approach in the field? Any final questions? Okay, so again, back to you, Martha. There was a question. You would need to get the video IRB approved, correct?
Yeah, absolutely. So what we did is we submitted the PowerPoint slides along with the script that Dr. Shiyanbola was reading. So the IRB saw the exact language she was going to say in the video. And that way they could, make edits if they wanted to the text rather than submitting the finished video to the IRB.
I had a real quick question. It's so interesting that you ask about pros and cons. I think I've never asked anyone cons before. It's sort of opening the door. It's giving you an opportunity to address concerns. Does it backfire? Is there a potential for someone to sort of, dwell on the negative or dwell on the aspects of the study that you can't modify and can't make easier for them?
I won't say dwell. Every personality is different. The biggest cons that we hear is not being able to randomize themselves into the one they want to be in. The second one is the money. And then the third con might be like timing, like far as like they might let us know like, well, I was able to meet you at this time. How does that work with my time in the future? Because after we initially meet them, it's actually very flexible. And so they just want to make sure their timing isn't rigid. So we have all different kind of personalities. We really do. But I can't say that anyone truly dwells in the cons area, but we do get them, and those are the top three.
Thank you, Delicia. Okay. Oh yeah. So I say so. We are going to wrap up in our last minute. Last slide. I believe we have one last slide. Okay, and so again, just to reiterate, the purpose of this adapted approach is to increase transparency in the way you communicate with your trial participants about research. The adapted approach, like we said, we really, really emphasize health and research literacy. You heard about our use of language, our use of pictures, open-ended questions, summaries, and teach back at the end to make sure people understand. And then again, that cognitive motivational interviewing process of providing them an opportunity to think about the study and discuss any ambivalence or unwillingness they might have about being in the study. And we are at time, 2:00 my time, and I think that is what we have. Thank you for joining us. I want to appreciate my the ENRICH study team members who are also here to be able to participate and answer your questions. And thank you for the invitation as well. And I'll hand it over to you, Anne.
Thank you so much. Are there any last questions folks have? Great. Well, thank you again. Really appreciate all the expertise of your team, and this was wonderful. Thank you.
Thank you.
Great. Well, take care, everyone.